Good morning. I bring greetings from Indian Society of Gastroenterology. A very warm welcome to another session of IST Masterclass. This is series number 4. I am Matthew Philip, the Secretary General of ISG. The theme of this series is challenges in day-to-day practice in gastroenterology. We have very eminent speaker as well as very experienced moderators for the session. At this time, I would like to acknowledge the efforts taken by the past president, the president-elect, and the current presidents and the GC members of IST in helping me out, charting out this program. And also, I would like to especially thank Sudipta Chowdhury and Bhaskar Nandi, who took special interest in this program. The previous sessions were well attended with very meaningful interactions with the faculty. I would like to inform the participants that kindly post your questions and we will try to address each and every issues you raise. And also there will be some poll questions. I request you to actively participate. Now, may I request our beloved ISG President, Dr. Sandeep Nichavan, to take over the proceedings and introduce the moderators. Thank you so much.
Good morning, everyone. Welcome to another masterclass of Indian Society of Gastroenterology. As a president of the society, I bring greetings from the Governing Council. This is the Series 4 we are running, and we have very, very eminent speakers for each session. And the previous sessions, as told by Dr. Matthew, have been well-attended sessions. Today we have very senior consultants, Dr. Rai and Dr. Ajay Kumar. Dr. Rai is a former professor in Health Department and a founder member of Gastroenterology Department, SMS Medical College, Jaipur. He has a keen interest in the subject and a vast experience of treating such patients of GERD. We have another stalwart with us, Dr. Ajay Kumar. He is chairman and head, BLK Liver and Digestive Diseases Institute, Delhi. He is also a very senior consultant, very, very vast experience in the subject. I think both will add value to our masterclass. Now I'll request Dr. Rai and Dr. Ajay Kumar to take up the proceedings further. Dr. Rai, please.
Good morning. What a great day it is that I'll be introducing today's speaker. She's a doyen in the field of luminal gastroenterology, and she is presently, Dr. Shobna Bhatia is presently the head of department and director of gastroenterology at National Institute of Medical Sciences, Jaipur. She was the former professor and head Department of Gastroenterology at Seth GS Medical College, KEM Hospital, Mumbai. She had been a very, very active partner in the activities of Indian Society of Gastroenterology. She served as the governing council member from 1999 to 2001. She was treasurer from 2002 to 2007. She had been coordinator for the various task forces, and one of the most important is the Gastroesophageal Reflux Disease Task Force, and she oversaw the data and collection on the GERD epidemiology for more than 20 centers in the country. And she was also part of the publications of guidelines for GERD. She is a core committee member of Indian Society Irritable Bowel Syndrome and H. pylori treatment. She had been the editor-in-chief, which is one of the most important posts in the Indian Society of Gastroenterology, and she was the editor-in-chief of Indian Journal of Gastroenterology from 2007 to 2012. She had been partner in international committee members in Asian Barrett's Consortium on Barrett's esophagus, Asian Pacific Consensus Meeting, and so many of these areas. And she had been an important part of the Rome Committee, as well as presently the Lion Consensus, which has been just published for the GERD, and she had been a member in this area. Her areas of interest are functional gastrointestinal disease and IBD, and research methodology, scientific writing, and editing. Total publications are more than 100. She received the award of Unichem Lectureship in Gastroenterology, ISG Olympus Mitra Award for Endoscopy, and NBE Excellence Award. We have the great pleasure in inviting her to present her subject on GERD, the new challenges. Dr. Ajay Kumar, please.
Thank you, everyone, and good morning, everybody. Thanks to Indian Society of Gastroenterology to take up this initiative and to introduce the legend speakers to talk about our day-to-day clinical practice issues. And well, friends, the legend that will be speaking on the subject has been introduced by Professor Rai, but the subject itself is the core issue for any gastroenterology in clinical practice. If you look at the outpatients, in any outpatient, your 1/3 patients will be 1/3 to 1/4 patients will be related with this disease entity. And this is the commonest symptom for which you are consulted. When you are in any social event, your friends and colleagues will consult about it. So the few things that I like to talk about, that why we are so much interested in this. First, it's very common. And it is a common day-to-day clinical challenge that all of us face and the future gastroenterologists will face. Two, it is not a simple thing to just say, give a PPI and that's the end of it. You will have hundreds of questions even after that, that what are the side effects of long-term PPI and what is the stage that you have to intervene as a gastroenterologist. With the advent of the newer diagnostic modalities, which help you in deciding to apply the newer treatment strategies, and whether it's an endoscopic or whether it's a surgery or the alternative medicines or the new medicines being developed, for everything, you need an update on that. And that is what when the gastroenterologist comes in picture. So I'm glad that the society has taken up this topic and of course the right speaker. And I'm looking forward to listen to Professor Shobna Bhatia. Over to you, madam.
Thank you, ISG, for this opportunity. Do you want to take 2 poll questions first before we start?
We'll take up the poll questions. Admin team, can you just share us the poll questions?
Yeah, it's there, madam. You're on, madam.
Yeah. So the first poll question is, a 45-year-old man who has heartburn that is not responsive to omeprazole 20 milligram twice a day for 4 weeks. The next option, any one of the following: switch to another PPI twice a day, immediate endoscopy, endoscopy after stopping omeprazole for more than 2 weeks, and pH metry while the patient is on a PPI. Can we start the poll? Can we start the poll?
Yes, it's being done. The admin team, can you show the result?
So we have the first part people have said is definitely not very popular, but people are happy with immediate endoscopy after stopping PPI and pH metry on PPI, which is almost 30% of each. So I guess that will change hopefully after the session is over. Next. But we have only 22 votes, so I think we need to improve on that.
That will
Can we have the next? That will gradually change. Next question. Next question. So what is the role of manometry in GERD? You have a manometry machine. A patient has been referred to you for GERD, and you will use it for all except any one of the following. Exclude major motility disorders like achalasia cardia, pre-operative assessment of motility, prove gastroesophageal reflux, assess contraction reserve of the smooth muscle of the esophageal body, and assess hiatal hernia. So which of these is not true? Can we have the poll on? So I think 50% of the people have said prove GERD. We're getting more votes.
Yes, now, madam, you can start your comments.
I think we have almost 40% of people saying that you cannot prove GERD by manometry, and the rest have given different answers. So we'll just go to the presentation.
So after that, they will correct
and
it.
In the first part, yeah.
Okay.
So I will share my slides now. Can I share?
Yes, you please share.
Okay. Okay. Can you see my screen now?
Not yet.
Not yet.
Can you see my screen?
Not yet, madam.
I am showing. Can you all see my screen?
Did you share?
You share your screen.
Yeah, it is shared here. Because on the iPad, it's not the same as
Can't see.
this thing. One.
Not as yet.
Okay. Let me put off everything and come to this. Okay. Share content is on. Screen broadcast. Yes, start broadcast. Okay. Can you see my screen now?
Now it is coming. Now
Yeah,
it is
coming now.
Now it is coming. Okay. So now let me open my file.
Now you open a file.
Can you see it?
Yes.
Yeah.
Yes.
You can go to
Okay.
screen.
So I think I tried to jump and this thing. So first of all, thank you, Dr. Rai, for giving a fantastic introduction. I was really happy to hear all that. Let me try looking at some of the management options of gastroesophageal reflux disease. As Dr. Ajay Kumar said, GERD is an extremely common condition. Almost 8 to 10% of the Indian population will have some form of symptoms of reflux. And there will be hardly anybody who will say that I did not have symptoms of reflux ever in my life, even after eating at a very heavy meal at a conference or at a wedding. So the definition of GERD was originally given by the Montreal team many years ago. And last year, a new team had met and they now have different definitions. So first is that the defined as a condition in which the reflux of gastric contents into the esophagus results in symptoms and or complications. And this is almost similar to the Montreal definition. The second part is the different one. That is, first, GERD should be objectively defined by presence of mucosal injury seen at endoscopy and or esophageal acid exposure, which is abnormal during a reflux monitoring study. So this now puts the ball in the court of the investigations. That means if a patient, this we usually use when a patient doesn't respond. If a patient responds, you move on and continue to treat the patient. So the first scenario is that there is a 32-year-old lady with regurgitation for 6 months and retrosternal burning for 6 months with a BMI of 32, and there are no alarm symptoms or other systemic symptoms. So in this case, it appears that this patient has heartburn and regurgitation, which is probably sour, the way she's saying it. So I would try to base my diagnosis on the base of symptoms. And that is what most of the societies have said, that if a patient has typical symptoms like heartburn and sour regurgitation, because there is acid coming up before the patient is on PPI, you can directly say that this is GERD. And you could also use some questionnaires like the RDQ or the GERDQ and try and see whether that fits into the diagnosis of your patients. However, many diseases can mimic GERD, and therefore, in the community, this is very useful, that is clinical history and sensitivity. But when you come to a specific center where most patients who come have not responded to the PPI, then in that case, this has limited sensitivity and specificity. So what does one do? The first is that you give a PPI trial, and I think that is what all of us do. Even the physician practitioner who sees the patient for the first time, and sometimes the patient does this himself, where he takes any tablet of a PPI or a ranitidine, just simply because he's got some symptoms. So usually we give the dose once a day for at least 4 to 6 weeks. And if the patient does not respond for 2 weeks to a double dose PPI, we say that this patient may have refractory GERD. You call it successful if the patient's most troublesome symptom, that is heartburn, has gone away for more than 3 days. The problem is that regurgitation does not go away as easily, because that is not only acid, that is acid plus gastric content, and that persists. So the limitations are that there is a high placebo rate, and symptom relief will be seen if there is erosive GERD in 70% of patients. In non-erosive GERD, which is almost 90% of the patients who come to us, only 50% of them will have some form of symptom relief. And if the patient has absolutely no GERD also, there is a high placebo response, and 30% of patients will get PPI relief. However, this will also lead to a lot of overuse of PPI. But I think a few weeks of PPI trial is what we would give. So let's look at the symptom-based diagnosis. And this is a very elegant study, a diamond study published in Gut more than 10 years ago, where they looked at whether the reflux disease questionnaire versus the family practitioners or the gastroenterologist, or symptom response to GERD, which was the best way to diagnose, and you find that a questionnaire and questions by the gastroenterologist were almost similar, and symptom response had a little lower sensitivity, but the specificity was almost similar. So any of these could be tried as the first part of your clinical evaluation of a patient. Because PPI treatment is less costly than diagnostic testing, and that is true maximum for our country. The PPIs are available at a cost which is lesser than the cost of a consultation of a physician. So what is the first management? First is start the PPI for at least 8 weeks, give it once a day. If the patient responds, stop the PPI. Now that's a difficult thing to do because the patient doesn't like to stop the PPI if his symptoms are gone completely. He doesn't want to stop it. So when you stop it, if there is symptoms recur, then you start investigation. Secondly, if there is incomplete relief, also you start investigating. In some situations, if the patient is not willing for treatment, investigations, you can always give some more weeks of treatment and then check, but always try and do an endoscopy of a PPI. The reason is this, that you will have patients who will have absolutely normal endoscopy while the patient is on a PPI. Even patients with grade C esophagitis, after 2 months of PPI, the esophagitis is healing, and there may be no evidence of any form of GERD when the PPI is going on. If you stop the PPI for at least 2 weeks, almost at least grade C and D esophagitis will reappear after 1 or 2 weeks, and grade B esophagitis will appear in another 2 to 3 weeks. So if off PPI, you find that there is LA grade B, C, or D, then in that case, or a Barrett's esophagus, or complications of esophagitis like a stricture, you don't need to do anything else. Your GERD is confirmed, and this patient can be continued on treatment as required and as per the advice of the doctor. There is no further investigation to be done. On the other hand, if there is a normal endoscopy, then that is when we've got things to do. So as I said, if mild symptoms, you don't need to do anything. Moderate to severe symptoms, do an endoscopy. So this is what the endoscopy looks like, and we are all familiar with this. So we just have to see whether there are complications like a Schatzki's ring, a hiatal hernia, or a Barrett's esophagus, and then decide what is happening. So a few years ago, this Saverino from Italy had this hypothesis that the history of GERD is not as straightforward as we think. So there may be situations where a person is NARD and is always an NARD, or non-erosive reflux disease. There are patients who have erosions and they continue with their erosions, may heal, and eventually develop some form of complication, whereas some people may have Barrett's esophagus right at the start, and they may or may not develop adenocarcinoma. Whereas the other spectrum, which is probably seems more feasible, is that patients shift from NERD to erosive to Barrett's esophagus, and from NERD, about 1 to 5% of patients would develop erosive esophagitis, and some of these might develop Barrett's esophagus over many years. Patients who develop Barrett's esophagus usually have more severe GERD or have an associated hiatal hernia, and this happens irrespective of the treatment that you're giving them, because sometimes they're not responding to the treatment that we give. Now, till the last 2 years ago, people thought that LA grade B was actually included as non-erosive reflux disease. Till these data came out, some came out last year, some came out this year. And they found that if you take patients of LA grade B and C, it's a little complicated graph. If you look at patients with LA grade B, A, B, C, and you do their pH metry, you find that in LA grade E, grade A, less than 20% of patients have pH which is abnormal. LA grade B, either the pH is abnormal or there is impedance abnormality, but eventually most patients will have some form of acid exposure which is evidenced. And therefore, now, as of last year, the committees have felt that grade B esophagitis is a conclusive evidence of GERD, but grade A is not conclusive. And therefore, grade A patients, before you give them long-term PPI, we should be investigating them. Unfortunately, the symptom profile of grade A and B and even C sometimes is almost similar, and it's very difficult to make out on the basis of symptoms what is happening. Now, when a patient doesn't respond to treatment which you have given, the usual problems are poor compliance. Almost 50% of patients, when they start responding at the end of 3 to 4 weeks, they will start taking their treatment as and when they feel like, maybe alternate day, maybe just as required, because they feel that daily treatment is not necessary or nobody has counseled them. This also happens in Western countries because of the cost of therapy. In India, most of the PPIs are not as expensive. And I think the most expensive PPI will cost the patient less than 500 rupees a month, as compared to a famotidine, which might cost the patient something like 30 or 40 rupees a month. So PPIs as well as H2RAs are not very expensive in India. The patient may continue to have reflux despite the PPIs, or there may be comorbidities. However, there may also be a misdiagnosis. A patient with eosinophilic esophagitis, achalasia, may also be continuing to have symptoms despite the PPI because the original diagnosis was not correct. So how do we approach a patient who comes to us, has a normal endoscopy or has something else? So first question is there reflux? And are the symptoms due to reflux? So there are so many tests which are described. And for the first part of the talk, I'm going to talk only about the investigations and then go on to the therapies in the second part of the talk. So when we do the endoscopy, I already showed you all pictures of reflux. If a patient has been continuing PPI, the additional benefit while on PPI is only to find out whether there is Barrett's esophagus, which you will find in less than 10%, and erosive esophagitis in a that less than 20% had grade C or D esophagitis. However, endoscopy in refractory GERD helps because an eosinophilic esophagitis, where at least 5 biopsy samples are to be taken, can be ruled out. You can find whether there is stasis, and sometimes apple esophagitis or epidermatitis bullosa, which may be there, and you can see that lesion. So you can see here the first one, there are multiple rings, and the patient has eosinophilic esophagitis. There may be viral ulcers, candidiasis, etc., and you can take a biopsy. But if the endoscopy is normal and the biopsy also is normal, of course, we don't take biopsies in everyone. So the first thing in esophageal manometry is it does not diagnose gastroesophageal reflux. So why do we do it? We do it because has to be and you see here in this parametric that in the part,
Shobna, your voice is breaking.
knowledge of manometry. I'm not going to learn manometry. So in the lower zone, high pressure zone, which is green, zone where high pressure zone.
I think connectivity is poor.
No, we can take up some questions if or we can ask some questions directly. If we lost Ajay Kumar sir, you can tell your experience about and some comments about GR. You have got a vast experience, no?
I think what Dr. Shobna has highlighted till now is that it's a very common disease. I'm just starting from the basics, that it is due to the reflux of the acid contents into the abnormal reflux of acid contents into esophagus, and erosive, when you see erosions, at least does not a definite diagnostic of GERD. You have to look at you have to make sure. Fourthly, Dr. Shobna, if you're ready, then we'll move on to that.
No, I was ready. I think I suddenly got muted. I don't know how.
Okay, now
there must be some problem. Okay,
no, you carry on because we can always come to the questions later on.
Okay, so what we can do
what you have
is
said till now.
Okay, fine. So I can just finish this part in another, say, 10 minutes, and then we can move to the questions.
Okay.
Okay. So I'm continuing to share this. So the reason that manometers, which may be achalasia or EGG obstruction, and now you can actually look, I mean, you can do some tests to see whether the patient has
Dr. Shobna,
a lax.
We don't see the screen, your screen.
Okay, when I come to Zoom, there is a problem. Okay, I'll just stop share. Okay. I think you can take the questions now because there's some problem here again.
So the other thing that when I was talking, the other thing was that what she's beautifully told us, that endoscopy in GERD, you don't need right in the beginning to start the treatment unless there are red flags, and she'll probably talk more on detail, but there are definite indications of doing endoscopy. But before that, for diagnosis, a PPI trial is a good enough trial in a significant number of patients, not in all. I think with that, if any questions have come up from anywhere, from the audience? Okay, if...
Sandeep sir, you can raise questions. Dr. Roy?
Yes. My question to you, Dr. Shobna, is that what are the strict indications that you must do an endoscopy right in the beginning rather than waiting for it?
So that's a very important question. The first thing is patients who have any alarm symptom. For example, dysphagia, even if it is a mild dysphagia, or a patient has recent onset reflux, patient is losing weight, has a GI bleed. These are patients I would do the endoscopy right on day one. I will not wait. In other patients, I'll say, try a PPI for a few weeks. And if you don't respond, then I would wait again for another few weeks. And then I would do the endoscopy.
No,
as I said, I don't want to miss. Yes. Tell me, Dr. Matthew.
Now, how many days you wait till you say that the patient is not responding. And another question which I want to ask is that suppose you have started with a normal dosage of PPI, and before doing endoscopy, provided there is no alarm symptoms, will you escalate the dose and then do the endoscopy, or when the conventional dose is not responding, will you proceed with the endoscopy?
So that is where the issue of diagnosis of refractory GERD is. So there are many people who feel that the original diagnosis of refractory GERD was standard dose of a PPI. But standard dose of a PPI, when you escalate it to a double dose, or when you change a PPI and use a double dose of that PPI, you find that the effect is add-on is only 20%. However, it is better to use that 20% advantage, double the dose or change the PPI, and then wait for about 4 weeks. If the patient is not going to respond, he'll tell you at the end of 2 weeks, there is absolutely no effect. In that case, I would stop the PPI and then do the endoscopy. So the key thing is now that unless you stop the PPI, erosive esophagitis is going to be missed in most patients, which is the reason
Shobna,
why.
double?
Hello, yes?
Same time you give the double dose or you divide the dose in two?
No. So I always divide the dose. And there is a very old study on rabeprazole. You see, there were people were using 20 milligrams 2 times a day. And then they decided to further divide it into 10 milligrams, 10 milligrams 4 times a day. And they found that gave much better relief than a single dose.
I think there is some problem.
40 or 80 milligrams.
Madam?
Yes, Dr. Matthew?
Yeah, no. In between, we lost connection with you because the internet connection appears to be quite good. The signal blocks are quite good, but I don't know what's happening there.
My connection is quite good. What
can you just try? Can you just try sharing slides again?
Nearer to my router.
Let me ask a question to Dr. Ajay Kumar as well as Dr. Ramesh Rubai. In your practice, when you do a biopsy in a patient with a reflux disease? Dr. Ajay?
No, I personally do not do biopsies in all those patients of reflux esophagitis, except for the refractory esophagitis. When we are investigating, then I want to rule out theoretically eosinophilic esophagitis, but I don't find much evidence in our population. I'm not sure what is the situation in your setting, that we hear about it quite a lot, we talk about it quite a lot, but we are not getting the documented cases of eosinophilic esophagitis. Yes, and yes, but Barrett's I will biopsy only if I suspect endoscopy. I mean, if I see on endoscopy that there is a Barrett, then there is no debate that it has to be biopsied.
Why I told this is there was a study from India on reflux esophagitis biopsy and to look for eosinophilic esophagitis. And when there is Barrett's esophagus, definitely we have to do for that suspected Barrett's esophagus. And when there is an inflammatory nodule, or there is a nodular or polypodal elevation, I think we are supposed to do. Probably it looks more of inflammatory, but I think when there is a lesion other than erosion, then I think it's better that we can do. And Shobna, are you?
Yes, I'm here.
Share the screen. By the time we'll take more questions. Dr. Robrai, any change of opinion on the biopsies?
Unmute. Dr. Ayesha, unmute yourself. Yeah,
can you see my now?
No, we don't see your screen.
Okay, fine. So let me just.
And Dr. Ajay, one more thing, in your practice, will you check for Helicobacter pylori in patients with GERD? Anyway, you're doing endoscopy.
My answer is no. Yes, if I have, I mean, even if you ask, okay, I think let's first look at Dr. Shobha.
Yeah, let it come.
Screen is coming.
Yes, very good.
Yeah.
It's
Can
coming.
you see now? Okay.
Yes,
Yeah.
yes,
Please carry on because we
Yeah.
don't.
Okay. So the main reason that you do a manometry, but let me just answer that question on biopsies, is that if a patient has not responded, I think the best thing is to do a biopsy. If the patient has not responded, then do a biopsy while the patient is off PPI, because EOE can be diagnosed best when the patient is off PPI. And secondly, of course, we talked about the evidence of esophagitis. So let's come to manometry again. So the main reason you do a manometry is to look for an alternative diagnosis. The second reason is to find out whether there is good esophageal reserve, which is done by a multiple rapid swallow, where you give the patient 5 rapid swallows and see whether the contraction is better than with the ordinary 5 ml swallow. Now, this is something new that's come up, and I think residents need to look at this. And some of you who have manometry can even try this out. So when you ask the patient to do a single leg raise, you find that the abdominal muscles will contract, the diaphragm will contract, and immediately the LES will also contract, and there will be absolutely no pressure transmitted to the esophageal body, which means that the LES is competent. On the other hand, if you see that there is a common cavity phenomenon, I think the figure on the right, where the whole thing is looking green, is that's a common cavity phenomenon occurring, where the pressure in the esophagus rises. You find that this is a situation where the patient has a poor gastroesophageal junction, and therefore the esophagus is getting transmission of the pressures that are coming from the abdomen. And if you do a pH metry at the same time, you find that the sensitivity of this test for diagnosing reflux and an incompetent EGJ is almost 80%. So therefore, this may be one test which may be added to our armamentarium during manometry without actually having to do much extra investigation. The newer thing there is the addition of impedance to manometry, which is that the impedance sensors are on the manometry probe, and you find that this bolus flow is seen very well. And you can see this bolus flow as pink.
Dr. Shobna, your voice is gone.
That there is some break in the contraction, and at that time the bolus is still in the esophagus, which gives the patient some kind of discomfort, which may give the patient some form of dysphagia, and this will tell us that the patient's esophageal motility is not good. Some of the mimickers of gastroesophageal reflux are rumination and belching, which is supragastric. So you find in the first part that there is this red which is coming intermittently. The LES has not relaxed at all. And if you looked at this tracing before this picture was taken, there are multiple episodes of swallowing, which is actually supragastric belching on the right side. And that's also a transient esophageal, this is a transient LES relaxation. On the right side, you find a rumination episode. And this was the supragastric belching, where you see the air escaping from the upper esophageal sphincter. I'm very sorry about this mistake. So what are the findings in GER in manometry? You look at the LES pressure, look at the height and hernia, and see whether there is more than 80% failed peristalsis. The next test that you do is an ambulatory pH testing. So pH testing, which we all have in India, is the ambulatory transnasal probe, which may be a single probe, a dual probe, or an impedance pH testing probe with 2 pH probes and the rest of them are impedance probes. The international community is more in favor of the intraesophageal pH capsule because you can measure pH for more than 4 days. And this is what we do. We put in the probe through the nose into the stomach. The pH probe which you want the measurement in is placed 5 centimeters above the manometrically defined LES. And here you can have pH or pH impedance. What the probe measures is pH less than 4. The recorder above records everything. And the recorder also has these buttons for symptoms, for medications, for lying down, for meals, everything. And it's almost like a little video game. So patients have to be taught how to use this. And then they use it in over 24 hours while they are moving around doing their normal activity. The wireless pH metry, which I said, is when you have some patients who do not tolerate the nasal probe. And the advantage is that it can be placed during the index endoscopy itself. So if you find that the patient does not have any esophagitis, you can talk to the patient beforehand and tell them that if you don't find esophagitis, we can fit this wireless probe in, and this will measure pH for up to 4 days. And of course, one of the side effects is that the patient may have chest pain, or that this probe will slip in about 5% of cases. But otherwise, you can record tracings for about 4 days. So when you have a pH which is less than 4, now when you have this 24-hour tracing, the computer will calculate the pH that is less than 4 and tell us whether there is reflux or no reflux. So pH less than 4 for more than 6% of the time, sorry, in a patient who is not receiving PPI is conclusive of gastroesophageal reflux. The previous studies had shown a pH of 4% of the time was the cutoff, but now we know that between 4 and 6 is a plus minus and it's not definitive. So more than 6 is definitive reflux because in normals or in people with heartburn less than 2 episodes per month, the pH values are between 3.9 to 7.2% of 24 hours. And therefore, if you take the lower pH values, you would actually be looking at normals rather than calling them reflux, and you might wrongly take up patients for surgery. So this all is done only for pre-op management. And total acid exposure value of less than 4% is normal, less than 6% is likely to be normal, and more than 6% is abnormal. Patients who have erosive esophagitis, the actual values for reflux for less than 4 are 9.6 to 27.6%. Now, what are the issues of pH metry? First is that an ordinary pH probe cannot detect non-acid reflux, which is either gas, or if a patient is on PPI, the fluid which comes up is not less than pH 4. And therefore, you need to add something else, which is the impedance. So this is the impedance pH probe, which has 6 impedance channels and it has 2 pH channels. One pH channel is placed in the stomach. And this pH channel actually tells us whether gastric acid is completely inhibited or not. If the gastric acid is not inhibited, then in that case, there is no point. You have to increase the PPI and you have to upgrade the PPI. Whereas if the gastric acid is properly inhibited, then the gastric channel will show that there is no acid. And then you can look at the non-acid reflux in the impedance channels. So when do we do this? This when there is atypical GERD. You can do this usually off PPI because you want to know whether the acid is coming up to the upper level of the throat. In patients who have already taken a PPI and they are responding, sorry, they are not responding, but they had either grade B or C esophagitis. You want to know whether the PPI is completely working or not. In that case, you put the patient on PPI and see whether there is acid reflux or not, and then you can optimize the PPI. This is what the graph looks like after 24 hours of, this is a 24-hour compressed graph. Now you look at this carefully. The bottom orange graph is the pH. The rest of them are impedance tracings. And there are so many of them, it's actually confusing. So you expand this and look at a reflux episode. So the computer, the software can detect when there is a reflux episode. A reflux episode will start from the esophagus, start from the LES and go above. So that means the reflux episode is going in a retrograde fashion from the LES to the upper sphincter. And here you see that this reflux is like a funnel shape. In addition, you see that the esophageal pH is about 3.2, which means that this is an acid reflux episode. So this is what the reflux episode looks like. Now, in this case, there is a reflux episode, but you find that the gastric pH is close to 6. So this makes it a non-acid reflux episode. We can stop here because the investigations are done. Yes, so we can stop here, take questions and go to management. Yes.
Dr. Shobna.
Yes.
Many times we have in 24 hours pH metry, those patients who are awakened in the night because of the night reflux.
Yes.
What is the correlation between the acid exposure and the symptoms? Because he has to push in the button as to when he has symptoms and how often the correlation is there. Because the previous authors...
hello. Yes.
The previous researchers had a different opinion than the present one.
So quite often in these patients, you find that the reflux and the cough or the reflux episode or the chest pain is there within 2 to 3 minutes. Either just at the time of the reflux or after the reflux. That means the reflux occurs and within 2 minutes, the patient has pressed a button. That means there is reflux at night and these patients are considered as reflux.
So there is a good correlation.
Usually, yes. So, but sometimes what happens, patients keep on saying that they have symptoms and on the pH metry, there are no changes. That means that we will label these patients as functional heartburn.
Okay. What about the bile reflux? Because you just mentioned that if it is non-acidic and this impedance one, can we detect the bile also? Because sometimes the duodenogastric reflux is important.
So that is a very good question, sir. In fact, previously, maybe about 20 years ago, there was a bile probe, which was called the Bilitech probe. Somehow it didn't do very well and was not able to detect bile very sensitively. The current methods do not check bile in the esophagus. All it tells us is the pH. So the pH is more than 7. We presume it is bile.
Okay.
Dr. Shobha, my question is basically clinical. Say at a primary or a secondary level.
Yes.
What is your advice that when should treating physician refer the patient for a pH, impedance, or motility study?
So there are only 2 or 3 indications here, and the indications are very clear. That is, the patients whom you are sending for surgery, or a patient after doing everything else is not responding. Those are the only indications for doing a doing the manometry or pH metry. So just prior to surgery, please do a manometry and a pH metry, because a lot of patients get into trouble simply because they have been operated with the diagnosis was not clear.
Should they ask for both impedance as well as motility, or they should ask for only one study? That's one. And second, should they be completing the repeat endoscopy before sending the patient for that?
So yes, I would do a repeat endoscopy. One is because just before doing any surgery, which is a fairly a permanent procedure for a patient with reflux, I would definitely like to do a repeat endoscopy to rule out any alternative cause. So all the investigations you do at this stage are for two reasons. One is to rule out an alternative diagnosis. The second is to prove that the patient has reflux. Because if the patient doesn't have reflux, then in that case, you are unnecessarily going to subject a patient to surgery.
Correlate to this subject, I was just putting word that NEJM study has shown very clearly with the pH metry and impedance that there are only very few patients who require surgery. And when they took about more than 110 patients, they could only make the patients less than 12 to go for surgery. So what is your take on this?
So that is the whole thing, that they even took up patients who had very little changes. I remember this NEJM study. This was from Stuart Speckler's group in Mayo. And they took up and they found that even patients with just symptom association probability without the complete GERD manifesting, they took up some of those patients for surgery, and they found that some of the patients actually responded. So but that group was so small, over a period of 3 to 4 years, they were not able to find too many patients there.
Dr. Shobna,
yes.
When you do the pH metry in such patients where your diagnosis is not clear, how many of them turn out to be positive for GER in your clinical practice?
So that's the whole thing. It depends on what your threshold for doing a pH metry is. So as we just discussed, it's an expensive procedure. So if it is an expensive procedure, if we start doing it in everybody, it is going to be an extremely difficult thing. So what I do is I select the patients who have not responded, or those who have come to me because they are going to be sent for surgery. That is the only time that I will take up a patient for pH metry.
They turn out to be abnormal in those select group.
So in that select group, again, patients who have significant symptoms, have had grade B esophagitis, will always have reflux. Okay. But there will be some who have not responded, had a normal endoscopy in the past. They are likely to be functional heartburns. So if the patient has a hiatus hernia, I know that it's very easy to say that there is a hiatus hernia. Patient definitely has GERD. But then in some cases, we might actually get foxed, and these patients don't have reflux.
Madam, now Matthew here. There are many endoscopic techniques of reflex management.
Yes.
What's your recommendation for doing? You know that there's arms, and all plication devices. So, would you recommend doing a pH monitoring as well as a manometry in these patients?
So first, let me tell you, manometry is done for a different reason. Manometry is done to find out whether there is a hiatal hernia, whether there is an alternative diagnosis like an achalasia, which we are missing before we send the patient for any form of therapy. Now, if the hiatal hernia is more than 1 or 2 centimeters, I think endoscopic technique should not be tried, because their response is not going to be good, and you cannot correct a hiatal hernia easily, though some centers are trying to do that by the sleeve, not what is that, the endoscopic clipping, whereas the ARMA and all that are not going to correct a hiatus hernia.
I think we will move to the next session. Can you please share this? Because we have got some questions on the chat box, which we'll take it at the end, and
Okay.
move on to the second part of the talk. Because
you want to take some more questions? Oh, by the way, we need to answer those questions which we had in the first part.
Poll questions? No, that questions are there. So, Dr. Ajay, can you just take up those questions?
See, the questions are more related to the treatment part, which you are yet to cover. So that's the
Okay.
Huh?
No, the first two questions were related to the investigations.
That's right.
Yes,
You
I
look at the
think- I
time now
think,
at 12:30. How many minutes
Okay,
of
okay.
presentation that you have so that we can do justice to the whole thing?
Okay,
So
fine.
Do
Okay.
the
So
presentation first, followed by.
I'll just share the screen now. Yeah. Can you see the screen?
Yes.
Is that okay? So now let us see what is the approach. So first question was, is there reflux? And we showed that if there was positive reflux or there was findings of endoscopic abnormality, we would say that this patient has reflux. So what are our aims of therapy? First is relief of symptoms. Second is healing of esophagitis, prevention and treatment of complications. So there are these general measures which we talk, where we say assess the use of drugs, see which drugs the patient is taking. For example, calcium channel blockers, derifylin, or the patient has some lifestyle abnormalities like he's obese, he has large evening meals within 3 hours of bedtime, lot of fats and chocolates, and lot of foods that can cause reflux. And then we can ask them to do a little bit of weight reduction and see whether that matters. So symptomatic relief with any PPI is about 77%, irrespective of the grade of esophagitis. And with H2RAs, it is about 50%. Now, this data is old, when the PPIs had just come. And at that time, H2RAs were not giving great relief to these patients. So when you look at mucosal healing, on the other hand, this is the same study. When you look at the mucosal healing, on the other hand, if you take a patient after 4 weeks, you find that the PPIs give healing in about more than 80% of patients, and H2RAs would give healing in about 50%. Even sucralfate gives healing in mild esophagitis in about 40%. So which PPI to use is the most common question that I'm asked. And you find that when you have a patient with mild esophagitis, there isn't much difference in the efficacy. And you find that the mean duration of intragastric pH suppression is maximum with esomeprazole and the least with pantoprazole. However, in a patient with grade B esophagitis or NERD, all the PPIs are almost equal. In a recent data which was published from David Graham's group, they found that if you take omeprazole as the standard, 20 milligrams is the equivalent, then pantoprazole is equal to 4.5 milligrams of omeprazole, and rabeprazole is equal to 36 milligrams of omeprazole. So it makes sense to say that if a patient doesn't respond, you can move to a higher PPI. If a patient is responding to omeprazole or pantoprazole, there's nothing more to be done. The only thing here is lansoprazole is approved for treatment in children and is safe. It's also approved for treatment during pregnancy, and therefore that is the preferred drug in these two situations. It is almost equal to omeprazole, but when the patient doesn't respond, we need to go to higher PPIs. So if you have these OD versus BD dosings, I said the difference is about 15 to 20%. So for healing at 4 weeks, the difference is only 30%. Whereas for different at 8 weeks, it is where the difference is seen. And the symptom relief is only 30%. So that's the surprise, that even when healing is better by almost double after doubling the dose, the symptom relief is not much, because there is some degree of esophageal sensitivity that remains even after the esophagitis has healed. So this is just another way of saying it. This is a graph drawn by Peter Karlas more than 10 years ago, that for esophageal healing, PPIs are excellent compared to placebo. But when it comes to heartburn relief, even after the esophagitis has healed, the PPIs do not cause that much relief as compared to the esophagitis healing. And of course, as I said earlier, the regurgitation relief is not much, because regurgitation is due to a lax LES. So in mild GERD, if ineffective, then you can go to a PPI, and endoscopic monitoring is unnecessary. And you can step down from the PPI and de-escalate. In severe GERD, start the PPI for 8 weeks, reduce to maintenance dose with half dose if possible. If the patient presented with a bleeding or an ulcer or any other complication, they need endoscopy at follow-up, and they require long-term high-dose PPI, and sometimes this PPI is required for a lifelong. So what about hypersensitivity? So suppose the patient is just not responding, or the patient has absolutely no evidence of reflux. Then we are left with neuromodulators, psychological interventions, and alternative and complementary medications. So the antidepressants that have been tried are TCAs, which actually work the best. The SSRIs, the SNRIs, even theophylline, tegaserod has been tried, pregabalin has been tried, but all of them don't work as well as the TCAs. And this is a set of randomized controlled trials for non-cardiac chest pain, and sometimes with functional heartburn. And you find that TCAs still have some degree of effect. The rest of them don't have much effect. So in patient has esophageal pain, means non-cardiac chest pain, then venlafaxine is the one that works the best. And the other things that can be tried are cognitive behavioral therapy, hypnotherapy, etc. So if you look at the whole GERD spectrum, then there are a few phenotypes, which is first is the acid reflux, the second is weakly reflux, weakly acid. The third and the fourth, fifth and fifth are essentially non-reflux, with one of them being hiatal hernia where there is motor abnormality. If you look at the investigation chart here, even if there is no esophagitis, patients with acid reflux will have a pH metry which is positive, but reflux hypersensitivity and functional heartburn are part of the acid reflux spectrum, where they are sensitive to acid but have a lot of visceral hypersensitivity. Patients with low-grade esophagitis have a lot of some acid reflux, but they also have some degree of motor abnormality, whereas patients with high-grade esophagitis have a lot of motor abnormality in the form of hiatal hernia, as well as a weak smooth muscle functioning. Barrett's esophagus again falls in the range of high-grade esophagitis, and if a patient has dominant regurgitation, then in that case, it is mostly the motor abnormalities associated with weakly acid or bile acid reflux. Sorry. So the usual approach to symptoms, and I'd like everybody to go through it. This is available free from gut, where this is available just 3 days ago. If a patient has troublesome symptoms, typical symptoms are heartburn, regurgitation, and chest pain. Empirical trial of anti-secretory therapy is correct, and do further investigations only and only if either the patient doesn't respond or the patient needs surgery. If there is atypical symptoms like belching, they do best with behavioral therapy and you prove that the patient has no reflux by doing manometry and pH metry. If the patient has atypical symptoms like chronic cough, asthma, globus, etc., then in that case, if the endoscopy shows no esophagitis, then do a further evaluation to show that there is no reflux in most of these patients. But don't continue the PPIs for a long time. And this is the test strategy, whether you do it on PPI or off PPI. You do it off PPI when you have not proven reflux as yet, and you do it on PPI if the patient had evidence of reflux like grade B or further esophagitis, Barrett's, and the patient is not responding to a good dose of PPI, which may be a double dose as well. And this is the confidence and diagnosis, which again says that if the patient has an endoscopy which is positive, then you're sure this is reflux, and you will do further studies only if you need further management issues. If it is non-conclusive in the beginning, that is LA grade A only, then you do pH metry. If the pH metry shows that there is borderline reflux, then you need to look at other things like impedance. You might look at the number of impedance episodes, and if you find that positive, then in that case, you might still label it as reflux. But in other cases, you would still say that this is no reflux. So in short, the management of reflux is not as easy as it sounds. In about 70 to 80% of patients, the patient will respond and you don't need to do anything further. But if the patient doesn't respond, you've got a problem. Thank you.
Thank you, Dr. Shobna. Dr. Ajay, Dr. Rai, there are many questions. We need to take up the questions now.
So this is the end of your presentation, Dr. Shobna?
Yes.
Then,
I have stopped the presentation in order to be able to take more questions.
We'll have the poll questions now. I think, it's better to have the poll questions.
If I look at the questions, Dr. Shobna, the first and foremost, there are a few questions on H. pylori, which Dr. Matthews started asking the question, but we stopped in between. The question is continuation of what Dr. Matthews asked, that in a patient of a straightforward GERD, what is the is there any rationale of doing testing for H. pylori? Number one. And number two, if you by any chance, those who test it, even if it's right or wrong, but will you treat, what is the impact of that?
So I would put it this is a very philosophical answer that I'm going to give. The first is, if there is no evidence of any peptic ulcer or gastric erosions, testing for H. pylori is actually not required. However, if you test it and it is positive, then there is peer pressure. The patient pressurizes you. He says, my H. pylori is positive. WHO says this is a carcinogen. Why are you not treating? There are multiple studies, mainly from Southeast Asia, showing that patients of reflux actually worsen after H. pylori is taken away. Secondly, patients after H. pylori eradication tend to put on weight because they eat better. When they eat better, the reflux gets worse.
No, so that clears that we should not be routinely
We should not be testing unless there is a gastric or a duodenal problem.
Fair enough. That's okay. Let's clear message to our people. The second thing, you said something that if you were to do endoscopy, you stop the PPI, otherwise you can misdiagnose or underdiagnose. Yes. At the same time, you are doing the endoscopy. If patient is not responding to the symptoms, you still think it is wise to stop the PPI for 2 weeks because you are doing it because patient is not responding to the treatment. That's the question from one of the delegates.
So this is a very common question that is asked, and the patient himself asked this question that if I am not responding, why are you stopping my treatment? Now, there are two reasons why a patient is not responding. One is that the esophagitis is not healing. The second one is that he did not have reflux in the first place. Now, if you go in and show a normal endoscopy, you are not any wiser, because if a person had esophagitis and it had healed. You don't know whether there was esophagitis earlier and it healed, or there was no esophagitis from the beginning.
But Dr. Shobna, as a naive, let me counter this question, that you have a significant proportion of patients who are non-erosive reflux disease.
Absolutely.
And so if you document the impedance studies and pH studies, that it is a patient of, what difference does it make whether it's a PPI-induced healing or it is a NERD? That's
So would you then, suppose I find that there is no reflux, okay, there is no esophagitis, then anyway I have to do a pH metry of PPI, right? And I would rather do an endoscopy and show esophagitis than do a pH metry. Because all along, pH metry and manometry are always going to be more expensive than an endoscopy.
Okay, that's a
Dr. Shobna.
logistical. Okay, Dr. Rupra, you want to ask? You want to put
Yes.
some? Oh, yes,
I
please.
just wanted to ask Dr. Shobna that before we tell anybody that he is refractory to PPI, you talked about the adherence. Would you like to give some emphasis onto the timing of taking the PPI? That's a very, very important, which should be told to our delegates and our students.
Yes. So the main thing is that when a PPI is taken, it has to be taken on an empty stomach, at least 30 minutes before a meal. And the reason is that PPIs will not act or will not be absorbed if there is food in the stomach. Okay. The second thing is PPIs will take 5 to 6 days to reach their peak effect. So therefore, they have to be told to take it at the same time every day if possible. And the response will properly start after 5 to 6 days. Now, very often, patient will say that I forgot. And I mean, that is natural, it is human that you take the PPI after a meal, you take a heavy meal at a wedding and then realize that today I'm going to get reflux, I might as well take my PPI now. It's not going to act as well as it would if it was taken on an empty stomach. And therefore, this has to be emphasized. It is also important to know that there are a few drugs which do not require an empty stomach. So, for example, H2RA will act even if it is taken after a meal, and it will act faster in such a situation. So, if the patient wants to take it as and when required, it is better that they take an H2RA, an antacid, or even these Gaviscon preparations. The other thing is that if the patient is non-compliant, there are dexlansoprazole does not require an empty stomach to be able to be absorbed. And the second group of drugs are the new PCAB inhibitors, which is the vonoprazan.
Just one more important point, that PPIs act only when the proton pump is active. And when you take food, right, you half an hour after the PPI, then only they will be active, and then you can block all those proton pumps. And that's a very important thing.
Yes, you are right, sir.
So there are a large number of questions only on PPI from the delegates. And I'll just put it in one or two categories. What is the maximum dose of PPI that you like to achieve? People are coming with double the strength of a pantoprazole of 80 milligram, omeprazole of 40 milligram, and so on, and esomeprazole of 80 milligram. Do you feel, how often do you actually require them, and do you advocate them or not? That's one. Secondly, how do you decide that this patient requires a long-term PPI in a patient of gastroesophageal reflux disease? Is it based on your endoscopy or symptomatology? And thirdly, the people have asked questions that long-term PPI side, because of the side effects people are talking about, what is your strategy to stop the PPIs or to downgrade the PPI dosage?
So I'll go backwards. The first is the PPI side effects. So lot of studies, the biggest one coming from Paul Mayadi, where there was they compared patients with PPI and without PPI with cardiac diseases, and found that the only significant side effect was enteritis or diarrhea. intermittent. The rest of them were not that significant. Though they did cross that 1 in the confidence interval, most of them remained less than 2. There are a lot of people who talk of renal diseases and PPI, but my personal experience is that I have had only one patient where I have proved that the renal disease was because of PPI. In other cases, I have not proved it. So nephrologists quite often stop the PPI because of this reason. Now I'll go back to the dosing. Now, high dose PPI, instead of high dose, it is better to space out the dose and give 4 times a day rather than give a single high dose of PPI. And that is because these PPIs, the effect drops after a few hours, after 8 or 10 hours. If you give a higher dose, the effect is even better, but again, it is better to space out the dose rather than give a single dose. Third is that there are certain situations where I would use even 80 milligrams of esomeprazole twice a day. And this specific case is for patients who are undergoing a lung transplant. Patients who are undergoing a lung transplant, the maximum reason for rejection is gastric acid. So you have to stop all the acid that they have. Otherwise, we can have problems. They are the ones who will benefit most whenever the PCAPs come into the market.
Dr.
Does that
Shobna,
answer your question?
There is one more question which is about alginates, use of alginates. Yes. Would you like to comment upon the acid pocket and the night reflux and the use of alginates?
Okay, so I had not covered a lot of these because I thought I'll keep it simple. So alginates have a specific effect that when they come in contact with acid, they are converted into a raft. And this raft floats on the top, and especially in patients with hiatal hernia, where the acid is going to come up. Instead of the acid, it's the part of the raft that comes up. And therefore, though there is reflux, it does not prevent reflux. There is reflux, but instead of acid, it's the raft. And therefore, esophagitis and mucosal damage is prevented. And therefore, the patient has relief in symptoms. I like to give it best just when the patient is going to lie down, because that's the time many patients have their nocturnal reflux.
Yeah, madam, what is the adding prokinetics in patients who have got lax esophageal sphincter? That is the commonest finding these days we get on endoscopy report. So is there a role of adding prokinetic to a PPI?
So prokinetics, like PPIs, have a short half-life when you give them. So you need to give it only when the patient has taken a meal. That means just before the meal, so that the gastric emptying can be faster. The reason that prokinetics are given is to increase gastric emptying. None of the PPIs influence a low LES pressure. So if I say that LES pressure is increased by 10% or by 15%, if the LES pressure baseline is 40 and it goes up by 10%, it goes to 44, which is significant. But if the baseline LES pressure is 10, which is in most of the cases with reflux, it will go up to 11, which is not much of an effect on the reflux. And therefore, you're using the prokinetic only to have a gastric emptying. And therefore, if the patient has a lot of bloat and regurgitation, we must rule out gastric emptying disorders before we submit these patients for surgery. And that is where patients with mild gastric emptying disorders, which occur in about 30 to 40% of patients with reflux, is where the prokinetics are most helpful. So I would ask the patient if they have bloat. And if regurgitation is a prominent symptom, in that case, I would give the prokinetic. For pure heartburn, prokinetics are not good.
And what is the role of surgery in this era of very effective PPIs?
So the role of surgery is very specific. Young patient, someone not willing to take long-term PPIs, he's read from the net that there are a lot of side effects. A patient with a hiatal hernia, large hiatal hernia, is never going to be healed by any of the medicines or endoscopies that you can do. And nocturnal reflux. And lastly, patients who undergo lung transplant, if there is evidence of significant reflux, send them for fundoplication after the lung transplant. So that is one of the new things coming up.
Dr. Shobna, There are a lot of talk about tricyclic antidepressants or the look at the hypersensitivity and other things. Now, in
Yes.
your treatment algorithm, what is your advice usually? I mean, prokinetic, Sandeep has already asked, but I will like to go further. That if you're using a patient on a PPI, he's not responding, what exactly is the stage where you like to add a prokinetic, or you like to give it right in the beginning, which is happening now across the board? Number two, when will you like to use drugs like tricyclic antidepressants or any other so-called to treat hypersensitivity?
Okay, so if patients have definite reflux and if their symptom is predominantly a volume reflux, which is regurgitation, then I would add a prokinetic. So that is very clear. I would not add a prokinetic. There is only heartburn, because heartburn responds well to the PPI. It is the regurgitation that doesn't respond, because the gastric emptying is slightly delayed. Also advise them to have small meals, and also advise them to lie down only 2 to 3 hours after having a meal. That helps in most cases. Then comes a stage where these patients, even after esophagitis healing, about 30% of patients will continue to have symptoms. And this is where hypervigilance comes in, which may be due to actually acid hypersensitivity because the patient had reflux in the beginning, or it is because he didn't have reflux at all, which is these patients have functional heartburn. In both these, I would start with a TCA, provided that the patient did not have any constipation. If the patient has constipation, I would avoid TCAs because TCA side effect is constipation. In others, I would try and give them SSRIs.
Madam, I think now Dr. Ajay and all faculty, we have only 1 minute left. So one more question and then we'll conclude.
There was a good question about endoscopic management of GERD, which Dr. Ajay initially asked. Would you like to comment upon that? In the era of surgery, addition of these tests are useful.
So I would say that there are many endoscopic techniques which have come and gone. So I'm just waiting for one which is proving for a long-term effect, including the magnetic sphinx and others. They are there, but I'm not sure how long their effect is going to last. And most of them are effective only and only if there is no hiatal hernia. Only and only if you prove that there is gastroesophageal reflux and the patient does not have grade C or grade D esophagitis. Please don't put grade C or D esophagitis into that group, because they may or may not respond and eventually will require surgery because their symptoms are just not going away because of the large hiatus. So I would suggest that.
I think we are coming.
So I'm waiting for a new technique that will do well at the end of this.
Thank you so much. I think, we had a wonderful session. So Dr. Sandeep Nichavan, can you make your final comments?
Yeah, thank you, Dr. Rai and Dr. Ajay for an excellent moderation of the talk. And a special thanks to Dr. Shobna for sharing his vast experience on such a common subject in such a simple manner with such crisp answers. So hats off to you three all for giving us the time to Indian Society of Gastroenterology. Thank you so much.
Thank you very much.
Thank you.
Thank you for joining. And once again, I thank all the participants, delegates who have joined, and there are some questions also, and for some of them we could not take it up. And we had a very practical discussion on GERD. There was some technical glitch in between due to the internet issues, but everything went very well. And the inputs from Dr. Ajay Kumar and Dr. Ramesh Ruba is well appreciated. They have done a wonderful, their very vast experience is shown, and we learned a lot from there. So thank you, Dr. Sandeep Nichavan. I would like to thank the admin team and all the governing council of IST, as well as Nisha, which has been doing a lot of support in collaborating everything. So thanks everyone. We will meet afterwards with another session, which we will inform you later. Thank you so much.
Thank you.
Thank you.
Have a nice day.
Thank you.
Thank-
Thank you. Bye-bye.